Hey everybody, it's Kevin and it's Donna, and welcome to another episode of the Med List. Donna, this day we're talking about something that is really interesting. I think genetics in general get a lot of people excited in a similar way that like around the water cooler kind of conversations about artificial intelligence, genetics are really similar. One time it was the big ones like 23andMe, ancestry.com, and you're figuring out like where's my family lineage. And a sentimental moment for yours truly today. Today marks my grandma's heavenly birthday. So she made it to heaven this day in 2018. And so when it comes to genetics, there's no one that I'm more thankful for than that woman. So I have to make sure that gets plugged in today, Donna. But we get to talk to somebody in your past that is thankfully living, thriving, and doing so well. Any intro piece you want to give us a tidbit before we get going?
Yeah, so I'm just so excited to have a past student of mine who is so darn successful join me and you on the Med List.
Awesome. Let's do it. All right. So without further ado, let me bring Lucia onto the stage with us.
Hello. Hi, Donna. Hi, Kevin. I feel like a celebrity being on here. Oh, my goodness.
You are a celebrity. You're near and dear to me, I'll tell you. This is a great connection. So excited.
Yes.
I'm going to tell people just a little bit about you, and then you can tell us more. So Dr. Lusia Fomuso, she is a pharmacist, author, pharmacy coach, which I just love that, public health expert, and I've watched you, a 2-time TEDx speaker, and that was just amazing. So I can't wait to hear a little bit more about that too. And I can't believe, how are you in pharmacy for 20 years? We'll have to mention that too. It was before degree, I can tell you that much. You're really dating me. But she has so many roles, from like a pharmacy technician all the way to leadership roles, and then also pharmacy manager. And now that you are medical affairs and just passionate about medication safety, which I love. And we talked a lot about this, how like deprescribing, of course, to me is medication safety, and the pharmacogenomics that you speak of so well and write on so well. So just a big part of medication safety in general. All these worlds are going to come together today. So thank you, Lucia, for being with me and rejoining your professor, I guess.
Yes. Thank you so much for having me. I'm so excited. And I don't get tired of talking about PGX. I don't get tired of talking about med safety. So anytime that topic comes up, I'm right there. And I'm so excited that you both brought me on today to have this conversation with you. And before I say anything else, I just want to thank you both for what a fantastic job you are doing for our profession, having pharmacists come on and just shine the light on all the wonderful things that pharmacists are doing in the profession, not just count, pour, lick, and stick, but so many other things, that are so impactful for the community. So I want to thank you both for that before I dive into myself. But like you mentioned, Donna, can you believe it's been so... Wow, it's been a long time since I was your student, but I remember a lot about you, your calm, your focus. Our project we did was going into the field and educating people, which is, this is something I love. And we actually did a paper on this. Do you remember that? We did a paper on this.
Yes, we did.
My journey in pharmacy started in 2002. So I started as a pharmacy technician. I should have sent you guys a picture of what I look like at that time. My first job in a pharmacy. I loved it so much. I knew that was what I wanted to do. I wanted it right from then. And what had happened was a friend of mine, well, kind of a distant family member, had lost their life because of the wrong dose of a medication. And so that sparked my interest. Like, so how could that happen? Why did that happen? And so I got my interest of pharmacy from there. And it's just grown ever since then. And so that's why medication safety is a big deal for me, because you all know the slightest mistake we make could literally put somebody in the hospital if we did a wrong dose, or, it's sometimes so little that we don't even notice it, right? And so medication safety, you can tell, is a passion for me, because I had someone lose their life from an error that was just a calculation error, and it was just so sad to experience. Mm-hmm. But I went through pharmacy school with Donna, and then I started working as a pharmacist, actually at Kaiser Permanente, where I had worked as a technician and then an intern, and then became a pharmacist. And then I fell into the draw of money to go into retail, and I did retail for a while. And during that time, I did some hospital work, but I can tell you I'm one pharmacist who was giving up money for my sanity, because I've taken a pay cut because it was not what I wanted. I wanted to be in a space that was speaking to me, and where I was using my skills and what I enjoy to impact people's lives. And so I started doing some consulting, got into pharmacogenomics because it spoke to my soul, because I had my mom tested, and I found out after she had a stroke that she's a poor metabolizer of the B4C1 gene. You both know this is very important in warfarin dosing. And so she was put on warfarin, and when we did the gene testing, I found out, okay, she's a poor metabolizer. This is useless. Why is she on it? Why are we watching what she's eating and all this stuff when it's not even doing what it's supposed to do? And so we had her switched out of that. And that sparked my interest into, okay, so how does this play a role in the other therapeutic areas? This was just one area for me, right? Yep. And I had to step back and go, okay, so this is playing a role in psych, this is playing a role in cardiology. And that sparked my love for what I do now. It sparked my love for doing the TEDx talk. It sparked my wanting to write books and to get people more aware of what pharmacogenomics is all about. I'll stop talking now, and I'll let you all ask me some questions.
Oh, that was fantastic. I think that your former professor knows me well enough to know that I'm totally going to pull something off the rails here for you, Lucia.
Wow.
Here's something that I love about the conversation you started there: how human you make yourself, right? I feel like it's easy for us to look as clinician colleagues and from a patient perspective that someone is just those little letters that follow our name, right? In general, without having the human aspects of your mom was impacted by something. You went through and you made career changes and career choices based on being inspired to be able to help people in general. And knowing some of the things that you've done, like writing books, are connected to you being a mother, and you wanting to educate your children about things in life. Can you tell us more about those books you've written a little bit, Lucia? We'd love to hear it.
Absolutely. So my first book is a children's book, which is titled Thank You, Essential Heroes. And that came from me trying to teach my son. He's 6 years old now. He was 4 at the time. Just trying to teach him that not only the people in white coats are heroes, We started to talk about everyday heroes, and he was like, I don't understand what you're trying to tell me, Mommy. So we started doing some drawings and talking about it. And I realized, wait a minute, this could be a fun project for other kids, just highlighting the cleaner. And that was in the middle of COVID, highlighting the fact that if the cleaners didn't clean the room, COVID would spread even more. That person is a hero. Highlighting the chefs. If they're not cooking, we're not eating. Highlighting the people at the grocery stores. If they're not there, where are we getting our food? Highlighting the utility people. Like if my Spectrum was not working right now, StreamYard would not be working either. So just the little things that we forget about, right? So that's what sparked that. And my son absolutely loves that book, and it makes my life so much easier at night, because I can just tell him, go read Mommy's book, and then I'll come tuck you in. And there you go.
That's super special. Did he help you see it, like when you were putting it together? Was he part of the process?
He was. He definitely loved, he picked the colors. He wanted to make sure people from different backgrounds were in it. He would ask me questions like, oh, at school, he was in pre-K at the time. At school, there's this person in there. Why is that person not in the book? And it was so exciting for me because then I got to make sure there were people of all races in the book. I got to make sure there was someone in a wheelchair in the book because we were having these conversations, and it pulled everything together. Yes, that so far out of everything I've written, that's my best book because the story behind it, it just warms my heart. Absolutely.
Oh,
you can see though how it would catapult you to this whole pharmacogenetics journey too. And you know, you're already on that journey, but to write the book for it, because you're looking at all sorts of different people inside and out, right? And trying to figure out their medicines and what's going to work best for them.
Right.
So I would love for you, if you don't mind, Lucia, to just kind of give a little bit of an introduction, because I don't know if everybody really knows what pharmacogenomics really is. So just for like people in general, whether they're, you know, in healthcare or patients themselves, caregivers, just what exactly is this and how do we use it?
Absolutely. And that was one of the main reasons why I did my TEDx talk on this, because I wanted everybody to be able to understand this. And just knowing that our genes are so different, and it's going to affect the way we respond to medicine, right? So if there's a genetic variation in our genes, it's going to affect the way the medication is metabolized in your body. It's going to affect the way that medicine works. And then it's also going to influence adverse events, side effects, which ties into medication safety. And so this touches so many areas of pharmacy and medicine that we don't even think about, right? So let me give some examples. Let me say you have a variant in your gene. The specific one for the pharmacy people is CYP2D6, right? If you have a variant in that gene and you're put on Prozac, let me say you're a poor metabolizer, guess what? No matter how high the dose is increased to, you're not getting any benefit from that medicine, because guess what? You're not metabolizing it because you're a poor metabolizer. And so you're sitting there thinking, what's wrong with me? Why is the medicine not working? Well, my aunt 2 doors down took it and it worked perfectly. So how come mine's not working? Am I just weird? No, you're not weird. Your genes are just different. And so you're metabolizing the medication different. And so what happens there is, at that point, you need to talk to your doctor, get a test done, and you can figure out what is the correct medication you should be on. And I love this visual right here. Just the fact that many people can take the same medicine and have totally different responses to the medicine. And this falls in different categories, right? We just talk about a psych med. This could be in oncology. And just imagine how terrible it is for someone to go through cancer and then be on the wrong medicine. That makes them lose their hair. They're having infections. They're ending up in the hospital because they're on the wrong medicine. Or maybe they have a variant on their receptor, like, for example, EGFR. I'm not talking about glomerular filtration. I'm talking about the growth factor receptor. And so if you have a variant in that, you're not going to respond to a lot of cancer medications. And so one person just taking a step back and saying, wait a minute, this person is having a different response. Do we need to do a test to make sure they're responding properly? It just takes that one person to do that, and it could change the whole outcome for a patient. And so we talk about warfarin dosing. That's a big one. Clopidogrel, Plavix. I think everybody and their cousin is probably on Plavix at this point, because heart disease is a big issue, but that's going to be a conversation for another day. But Plavix is a big one. You have Pacific Islanders and Asians who don't metabolize it. So can you imagine someone had a stroke, someone had some event, and they're put on Plavix because that's what the hospital protocol says that. But did the hospital protocol check to make sure this person is metabolizing it? And we can go into many more examples like this, but the message for everybody, and especially people who are not even in healthcare, is the fact that if you're responding differently, or if you feel like you're not responding to your medicine, have a conversation with your doctor and figure out, should you be doing a pharmacogenomics test to make sure you're on the appropriate medication for you as a person? Not because 10 other people have used it and it worked, but because you as an individual, you deserve to be taking what's working for you as a person. Yeah.
Yeah, I think that's a great breakdown. I mean, there's so much verbiage and vernacular throughout all of healthcare that it gets overwhelming.
Yeah.
So when we say the word pharmacogenomics, like genes and drugs, those
Yes.
is we often shorten them to PGX. So for the listeners, if I say the word PGX just out of habit, please know that that's exactly what I'm talking about with Lucia here.
Yes.
When we're using PGX, some of the things that we often encounter are some inabilities for us to know before we prescribe something, Lucia, right? So we don't know if that patient has the right drug on board before we prescribe it
Right.
based on the genetic profile, right?
Right.
And so there's different schools of thought on when you actually use pharmacogenomic testing. And some of it is you're just about to start a new drug. Are you going to do pharmacogenomics right before you're going to do that? Should you do an overall profile and see what that pharmacogenomic profile looks like for that patient? So no matter what's prescribed, you have a background and a foundation. And some do it retrospectively. You know, something's already been prescribed, but it's not working. What are your schools of thought there in educating both patient world and clinician world on how to go about that decision making process? And I know there's lots to go into it when it comes to finances, what's currently
Yeah.
paid for by insurance, et cetera. But please educate us on it.
Absolutely. I think this test should be standard of care because your genes are not going to change, right? You're who you are. Maybe the way we read genes might change, but our genes are going to stay the same, right? So if we have that on file, every time you're starting a medicine, it's already there. So if you would ask me, I would say that should be standard of care for everybody. So, but for specific clinicians who are sitting on here now and saying, well, not everybody's insurance is going to pay for this, or not everybody is going to buy into getting their test done, I say then look at the individual and then have that conversation with them, because it's so important to pull the patient into these conversations. Let me give an example for this. So let me say you have a patient who is needing pain medication, tramadol, right? And they've had several other pain medications and it's not working. And you're sitting there going, okay, I'm sick and tired of changing your medication. So let's do a test and figure out what's going on. And a lot of times that patient is going to sit there and go, yes, I want to do and figure out why I'm not getting any relief. And why is that the case? So a lot of pain medications are prodrugs, right? Once you take it, it gets activated in your body. So the same CYP we talked about earlier, CYP2D6, plays here. And so if that person is a poor metabolizer of CYP2D6, they're not converting tramadol from the prodrug to the active form, and they're not going to get any pain relief. So if you're having this conversation with someone, tell me if they're going to tell you no to that test. They will not, because now they understand the importance of saying, okay, maybe I need to be on a straight medication that does not need to be activated because what I need to activate these other drugs is not working. Yeah. And so I believe that having that conversation with the patient and pulling them in to be a part of it is so important. But to answer your question, this should be standard of care. Everybody should have this. Like right now, I've done it for myself. I've done it for my mom. And whenever we're starting anything for my mom, I'm looking at that list and going, wait a minute, let me make sure she's on the right thing. And we're not going to take chances. We're not going to waste any money on medication that's not going to work and it's going to save the time that she needs to get better. So that, for me, that's how I look at it.
Yeah. I love that. That's a perfect description for all those that when Lucia is mentioning some of these things like CYP2D6, and she's talked about some other things that are enzymes, one thing to be able to understand is that when it comes to pharmacogenetics in general, a lot of it is describing what our body is currently producing, particularly in the liver, when it comes to our enzymes to break things down and how well that works overall. But the one thing to re-highlight is that what Lucia is pointing to with us having the ability to have a pre-screening, so we already know prior to our healthcare provider going through and choosing drugs for us, it gives us a great tool that is still being developed even further. So there's more and more research coming out giving us better ideas of how our genes and our enzymes tell us how we're going to respond overall to a drug or what diseases are going to respond best to different drugs. And so I think that's important, Lucia. But the one thing that I'm curious from your perspective then is when it comes to both these two questions, and I'm going to pass it over to you, Donna, when it comes to pricing, right? When it comes to pricing and getting someone in the door with pharmacogenomic testing for them to have it, no matter what, you already have it on the table. where do you feel like things are moving so we can educate our clinician group? I know this is rare, Donna, for me to ask on the clinician side, but I'm going to ask you.
Right.
On the clinician side, how do we get them to be able to understand where that price kind of conundrum is coming and quality of testing? Because there are about 1,000 tests out there, and every lab that was making money during COVID became a pharmacogenomics lab the year later to be able to find some way to make money. How do we find those two things, quality aspects of testing and pricing, so that we can actually make what you're saying happen?
Correct. So I actually did, for myself, I did a lab comparison just for the same reason that you just said it. There's so many labs out there and it can get really confusing. And some of them will allow pharmacists to order the test, some don't, some are static, some are dynamic, and there's just too many moving parts. And so sometimes it's kind of hard for a medical doctor to pause whatever they're doing to do that research, right? And so this is where I say, pull in your office manager, pull in someone at your office to do the background work for your patient group. I can't really quote any one company because, of course, I'm not marketing any specific company, but there's so many of them out there. And now insurances are getting smarter. I'm excited to say that because a lot of plans are now pulling this onto their formulary and saying, why am I going to pay for you to take a $3,000 medication if it's not going to work? So that's why I say they're getting smarter. And so most plans are starting to pay for it. Medicare pays for it. And there's some of the labs that even if Medicare doesn't pay for it, because someone might have a different type of Medicare, if it doesn't pay for it, they'll make sure that patient doesn't get a bill. So there's just so many options out there. And if that office invests the time to have, let's say they're a nurse or an office manager, do the research in their area and figure out what labs, especially the local ones to them, are doing this test, the cost will be reasonable. Most insurances will pay for it now. And it's so worth taking the time to do that. Not only, let me speak in the language of the doctors as well. So now you have something else you're billing for and you're making more revenue for your business. So not only are you caring for your patient, but this is some other service that you are able to bill for your practice as well. So it's a win-win, no matter which way you look at it. It's definitely a win-win.
Lucia, question for you. Is it true, and I could be confusing this, is it true that you have to like almost pick a menu option depending upon some of the labs too? So where, you have like all these tests that you could have done and you kind of have to pick and choose? Or is it, I'm going to get my genetic testing done and you get everything done always?
So there, different labs do it differently. You have some labs who only test for 23 genes and some who do a whole gene sequencing, and you have some who only focus on psych genes. I recommend you doing a whole gene sequencing. That way you have, it's almost like a dictionary in your house where you can just go reference it, right? But if a doctor works in this specific area, therapeutic area, let me say you're a psych doctor, you could choose to partner only with a lab that does the psych genes. So that's kind of how I would look at that. There's no right or wrong answer to that question, really. If you choose to focus on one area because that's what you do, that's fine. But as a patient, I would recommend you get a whole panel so you have everything.
So if a patient is taking this upon themselves, then because I do know some labs do it independently, and a patient can actually, they don't have to wait for the doctor to actually say, oh yes, you need this. So they can actually pursue their own, but to look at something that might be more of a gene sequencing, that would be a better option for them for all sorts of different things that may come their way.
Absolutely. And pharmacists, a lot of pharmacists do this as well. And so you can find a pharmacist in your state by looking at findyourpharmacist.com and go to your state. It's going to show you all the pharmacists who are able to prescribe this and get the process done for you. But yeah, you're spot on. So you can pursue this on your own if you want to do that without your doctor and just have that for your records. Absolutely fine. I was having a conversation while in the hospital when I just had my baby 6 weeks ago. I was having a conversation in the maternity about why don't they offer this to moms? Because I would want my newborn to get this test done. That way I can make sure they never take something that's not going to work. Why put that in their body if it's useless? So I do believe there's so many ways we can look at this and stay ahead of the game. Yeah.
Yeah. Lucia, do you see other like instead of just prescription meds, but possibly herbals and supplements and things such as that. Are we seeing that information combine with those other alternative fields, if you will?
Yeah, so that's really called nutrigenomics, and that looks at all the different stuff that we focus on. So like the vitamin Bs and all the different vitamins that are out there. And it's interesting. I actually had a patient who was an ultra metabolizer of folic acid. And so while going through her pregnancy, she's thinking she's taking folic acid. She's really not, because her body's clearing it out so quickly. And so there's so many ways you could use both pharmacogenomics and nutrigenomics. I'm not an expert in nutrigenomics. I do dabble in it a little bit, but I recommend it. If someone is having a question on why do I take my calcium and I still don't feel like I'm taking any calcium, sure, get it done. It's worth it. Yeah.
Interesting.
So look beyond your box supplement stores too, because there's a lot of information out there that we still need to be super careful of. Like you could be like mega dosing on things that aren't even providing any benefit for you.
Correct. And I want to highlight one point. So the aspect of not only just your genes and the drug, there's also drug-drug gene interactions. I'll use the same example we've been using so we don't throw everybody off. So let me say that same CYP2D6 we've been talking about, that particular gene, someone is on duloxetine, right? That's an antidepressant. That duloxetine is metabolized by that CYP2D6, but it also moderately inhibits that CYP2D6. So now imagine you have someone who's on that duloxetine and you're trying to add tramadol. Let's stick with the same example. And you're trying to add tramadol to their medication list. So you're moderately inhibiting CYP2D6. You're not going to properly convert tramadol to the active form. So even though you don't have any issues there, but just think about now you're taking two drugs and one drug is affecting the way you're metabolizing the other one. So it's very important to keep that in mind as well for clinicians, just to note that it's not only a gene drug reference, but there is a drug gene reference as well. But there are a lot of resources which you can use to check all of these and make sure that your patient's medication list, your patient's med list is complete and it's clean and it's appropriate. Yes.
Yeah. Thank you for highlighting that, because I typically do that. So how does this affect the med list? You said it. I mean, you have to, thank you.
See, so when it comes to, I guess, another piece of the equation. So when I was doing my PGX training and nutrigenomics training, the one thing that was really fascinating was this piece, right? We're also individually different, which is amazing. But yet we're all exposing ourselves to so many different things that also plays a major role. Really the nature nurture, right, component of life. So our genetics tell part of the story. And then just like you do in your practice, there's a comprehensive component in order to make the genetics meaningful at all. So for example, a lot of nutrigenomics training, at least to date, will say that most people's evaluation of their genetic profiles really will tell most people the same thing. They usually need a high quality multivitamin to be incorporated, right? That's the usual kind of end of all this information overload. That's what you arrive upon. And the exact same thing can be said about pharmacogenomics when it comes to, there's still going to be some variability within individuals depending on X number of factors. What other drugs are you taking? Not even drug-drug gene interactions, but just drug-drug interactions or drug disease interactions, et cetera, right? And so when you have all these other factors that are getting weighed in, right, that make it a very complex soup that we're trying to cook here, what do you feel like are, and I don't mean for you to have to go back on everybody should be screened, but if we had to just say this number of individuals should be screened, where do you feel like the greatest level of evidence currently exists that pharmacogenomics can really make an impact for these types of patients?
So this I kind of cover a little bit in my book. So my book touches a little bit about background, a little bit of history, talks about some little definitions of what people should know. And then I dove into some areas that I think are the most important in my opinion. So psych is for me the number one, just because a lot of times we have people on the wrong psych meds and people are suffering for no reason. The other one is cardiology. we have so much heart disease, and sometimes we have someone on 4 high blood pressure medicines and we're saying they have resistant hypertension and all this stuff, when sometimes we just don't have them on the right medicine. Then you even have your GI stuff. That's stuff that everybody should really be pausing and going, why am I dealing with this all the time? That is also an area that I think we need to really focus on. So for me, those are the top 3. That's not to say that those are the other ones. Those are the ones that I've spent a lot of time in. Another one that I don't know much on is oncology. But like I said before, I would not want to take a medication that will make my hair fall off if I don't need to, or maybe end up in the hospital with an infection if I don't need to. So if you have cancer, have this conversation with your doctor. There are so many other ones though. And so we should not only put these specific ones as the highlight. I did highlight them in my book because I do think it's an important conversation, but let's not limit it to that.
Yeah, it's interesting you mentioned oncology because that seems to be the most advanced field of pharmacogenomics, right? That's something that is being anticipated already to make sure those things happen. For most people in the breast cancer world, like everyone has heard of a HER2 receptor. Is this one Herceptin drug going to work well or not? And really is dependent on what are you getting back on these studies. So thank you so much for leading into that. So with those 3 then, when you say the word psych, what specific elements of psych? Can you dive just a little bit deeper into that one in particular? Because I think that when it comes to where can we use things, warfarin, for example, right? Warfarin, for all those folks that are out there taking it, I hope it's working really well. I hope that your INRs are fantastic. I hope those green leafy vegetables are not difficult for you to manage. And I hope that you're taking it because it's been working for you well, not because you can't afford a Pixaban or another drug, right? But for the most part, we're seeing a shift from some of these drugs, Lucia, that were chosen previously and were monitored and were difficult. And then we thought, pharmacogenomic testing would help. But we've gone away from the drugs almost entirely. We're not using them at the same rate and level. That's not true psych. We're using a ton of different drugs and trying to switch through them. So tell us a little bit more. Why psych in particular? Why does that one really redline for you?
Absolutely. So as pharmacists, I think you both know what happens with psych meds. When you start a patient on a psych med, they need weeks to find out if it's even going to work. And sometimes it doesn't work after weeks and they increase the dose and they have to take that again for more weeks. It's just a painful process for someone who's, let's say, for example, depressed, right? And so you're taking months and months just to get them on the right med that's going to make them feel better. That's really sad to even hear or to think about, when the solution could be so simple. Before you even start someone on a psych med, you have this test done so you can clearly look at it and say, hey, you know what, this patient is not going to good fit for Prozac, because Prozac is the go-to. As we know, Prozac is always the go-to, but not everybody can take Prozac. And so once you've identified that, you have shortened the time that that person's going to need to feel better by putting them, let me say, immediately on escitalopram or citalopram, because you know that person has a higher chance of doing better on. So for me, that's the main thing, because we have patients who suffer and go through months and the side effects. Let's not talk about the person who's going to be dealing with ED now and having to have that conversation with his wife and all that. There's so many things that go into picking the wrong medication, right? And so if we can eliminate all of these question marks to some extent and say, let's give this person a chance earlier to feel better quicker. Yeah.
So Lucia, you mentioned too that like with the cardiovascular, people are put on multiple meds to try to get their blood pressure down, and sometimes still unsuccessfully because they're just not on the right meds. But we also see that in psych too, with even depression meds, right? Or meds for anxiety. We just see this addition. And I know we get very concerned about that, and talking about other side effects too, some of the cardiovascular, the QTc prolongation and anticholinergic burdens and all these other things that are going on with the patients. Yeah. So, I'm wondering, like you're saying, why is it that maybe only selective insurances or offices or whatever might be looking at this when immediately they're thinking there's no response, or why would somebody be on these 4 meds? Why do you see any change or shift happening where we're like, okay, time out. You've tried this many, kind of like we do the step therapies with insurance. Okay, you've tried this many.
Yeah.
Let's make certain you get this test done versus let's keep trying. Do you see any shifts like that?
I think it's getting there. You still have a lot of clinicians who don't understand it. They don't want to deal with it. They just don't have the time to go into it. And that's where the problem is, because once they listen and understand it, a lot of them are right on it. They're like, wait a minute, why have I not been doing this? Why have I been stressing my patients and myself out and having to have people come in 10 times for no reason? And so once I actually went into a cardiology office and they asked me the question about this, and that just made my heart so sweet. I was so happy, you know. I was like, yes, let's talk about this. And so you're hearing a lot of questions around it now, which is what we need, because we can answer them. And if we don't know the answer, we'll look up the answer. But let's have the conversations. And I think we're there. We're in that space now where there's a lot of noise around pharmacogenomics, and that's the way forward. Let's understand it better. Let's start implement it as quickly as possible. But we're getting there. Psych, I think, is almost completely there. Oncology, like Kevin said, they're the top, but there's a lot of areas that are still not sure. I think pain clinics should be all over this, but we're not seeing that yet. Yeah.
Lucia, I did get your book, by the way. I just started looking at it and getting through it. But you gave a history lesson, and if I remember correctly, I think pharmacogenomics kind of really started to, really make its way into medical literature around 2003. Am I right with that?
Correct.
Yes. So, and the reason why that was stuck with me is that's when deprescribing became available in medical literature, is 2003. So our passions are both aligned in similar areas, if you will. That started in 2003. They basically are just making it through their pediatric phase, shall we say. And now we're like finally moving on a little bit more where, that first 20 years you see a pediatrician. Then after that, you get to see the PCP or, your regular internist. So I love this idea of what we're trying to put forth here and the conversations, like you're saying, that we're trying to share and make certain that both patients and providers are talking and they're communicating and they're asking questions and wondering and starting to figure this out a little bit more. So I found that really fascinating when I was reading your book. So thank you.
Thank you. I'm like, wow, that makes me know you really read the book. This is exciting.
Oh, I just started. I haven't gone through the whole thing. I literally just got it. I think it was yesterday.
Wow, that's so exciting. Yes, but you're right. This is such an important conversation, and we should continue having it. Yeah,
absolutely.
I think Mahmoud asks a fantastic question. Thanks for joining us, by the way. He asked this: is genomic testing also used in this area to determine doses as well? And so that leads me to my next question, Lucy. It's really, what other outside benefits are there that we often think of drug selection, as being a primary thing? Like if you can get your pharmacogenomic testing in some particular disease states, more specifically, you can choose a drug that's going to work better for you or your body's response to those individual medications. One thing that is also a thing I'd love for you to touch on is sometimes you can help with dose selection. Like, what dose should I be taking or starting out with? For Donna and I, I'm sure that we both have a certain inkling of start low, go slow, but get the general thought of deprescribing, especially in the geriatric community. But getting somewhere is important. And that's one thing I think pharmacogenomics that you'll highlight for us is great. The other piece is this, and I don't know how to phrase it in the best way for our audience, but I'm just going to go out and say it, Lucia. Oftentimes, the placebo effect is incredibly powerful. right? And there is something really special about someone having to go through the guesswork of choosing a drug and being able to say, this is what your body says would likely work best for you, right? Any stories on those two sides of the coin of, hey, this can help us choose a dose, or this gives a patient more confidence in the selection that's being made particular to them?
I love this question. And I'll start with the second one because I do have a story about it. So I actually had worked with a local psych office on this. And so they had a patient who was on the highest dose of Prozac and it wasn't working. And they were at the point where they're like, I don't want to do it anymore. Forget it. And so it so happened that I was there doing a PGX test for somebody else. And so I said, hey, do you mind if I have a conversation with them? And so we talked about PGX, the importance and everything, and said, wait, you've been having an issue here. So maybe let's try something else. Let's try to figure out if there's something else you're supposed to be taking. And so we did the test. It came back. And yes, surely he was a poor metabolizer of C2D6. They switched his medication. About 6 months later, I went into that office. I didn't even remember this guy, but he came up to me and he said, do you know that conversation we had made me have renewed hope? He's like, I'm taking my new medication. I don't know if the medication is working better or just the fact that you all said that. I feel better. So that's just to prove your point, Kevin, that the placebo effect is there. True, it is. But I also believe that it worked better for him because he got to take something that was working for him. So I wanted to get that story out of the way first. But let me go to Mahmoud's question about dosing. PGX is really under the umbrella of patient medication safety as well. Just because we think a certain dose of a medication is the standard dose does not make it the standard dose for everyone. There are some people who are poor metabolizers. There's some people who are fast metabolizers, and so they will clear it out of their body faster and might need a higher dose, or maybe a wider or shorter duration in between the doses. Someone who's a poor metabolizer might need a lower dose of that medicine. So absolutely, yes, it plays a big role in medication dosing. And also it influences how we decide a medication because of the adverse events, right? Let me give, for example, I keep forgetting this one. Is HLA-B 5701? Is that the right one for abacavir? I think so, for the HIV medication. That is one medication that has a terrible side effect. And so it's been found that about 5 to 8% of patients with that gene variant, that allele, will have that reaction. So if you did this test before and you figured that out, why would you give a patient that medication if you knew they had a higher chance of having that adverse event? So safety, dosing, metabolism, efficacy, all of it. And then maybe just even deprescribing, like Donna talked about. If you have someone on so many medications and you're thinking, they're having all these side effects, are all of these meds even doing what they're supposed to do? Why do I have them on this many? And so taking some stuff off that they don't need, streamlining their medication and making sure that what they actually have on there is doing what it's supposed to do for them. That is all things that you can use PGX to do for your patient. Yeah.
Beautiful. And as you probably noticed, I've been trying to lean toward the skeptic side and have you answer like, here's the reasons why you should consider it. But now I'm going to go the opposite side, Lucia.
Yeah.
I'd like to hear your answer on this one. I've seen more and more literature and more litigation out there related to this pharmacogenomic test could have prevented this very significant illness or issue, right, that ended up happening to a patient, including patient death.
Yes.
So now you're having the conscious minds of insurers, health systems, and providers thinking about, oh no, like, do I have to do this test in order to avoid a lawsuit if I ended up hurting someone and I could have done pharmacogenomics instead? That's there, and the balanced approach of that, to be able to understand what is best for our patients and to avoid, I mean, we do live in the US healthcare system. So the almighty dollar and the almighty judge are a very difficult combo to get over. But tell us your thoughts there on where do we sit next when it comes to litigation and PGX?
It's really a touchy topic for sure, because you're talking about people's lives and people's health, right? So it's a hard one to talk about. However, if I were to answer this question for a provider, this is what I always tell them. What does it say in the black box warning? Is there any language or anything in there that says there's potentially a chance for someone that has a gene variant to have an issue? If there is any language in that, in the prescribing information that says anything like that, to be on the safe side, just order the test. It's very easy to do, and get it done is going to help the patient in many ways. Right. So now if there's no language in there about any of that, and you decide to do the test, great. But if you don't do the test, I don't think you will have an issue by not ordering the test. So that's the way I answer it for them. I don't know the best answer for this, because like I said, this is such a touchy thing because you're dealing with people's lives. But to be safe for a prescriber, if you're trying to make sure they don't get sued, that's the way I would look at it. So look at the prescribing information. What does the language say? What resources are out there that are saying you should be testing or not testing? And are they backed by the FDA, the CDC, or whatever? And that should help guide you on making the right decision.
Super helpful, especially for those out there that are following the bouncing ball of, do I look at CPIC? Do I look at PharmGKB? Where do I need to go in general? And it makes so much sense, Lucy. I love that you point out when it comes to what are the federal guidelines saying, what does the FDA currently list inside of their drug listings and apply to what we're credentialing ourselves under for individual provider status. It makes sense to be able to follow those FDA guidelines and what's been highlighted at the very least. Love it.
And the FDA has a list of drugs that, there's very, very clear direction on, these are the drugs that we think you should be testing on. And so there's over 200 of them. Yeah.
I wish them and CMS would just get together sometime soon.
That would be nice.
Off to you now.
That's great. Well, Lucia, I just want to say thank you so much for being with us. This has been enlightening, and definitely you can tell that you are so passionate about what you do. So thank you for that. I do want to highlight your 3 books. First, your children's book, Thank You, Essential Heroes. And you started off telling us about that and how it was really a collaboration with your son, which I just absolutely love.
Yes.
Fabulous. You have another book, Stress Relief Promotes a Blissful Pregnancy. And right?
Yes. I actually just went through one of those.
Yeah. Even though I probably won't have that issue, I think I might be getting it for some next generation folks. And then Pharmacogenomics Basics, which is really just out, right? It just came out.
Yes. Literally this week. Yes. Yeah.
So that's awesome. So Lucia, again, another passion of ours. I just came out with my workbook this past week too, the MedStrong workbook. So, we are still paralleling here in our lives.
I love it. I love it.
It's great. And just congratulations to you. And I hope you're obviously doing great. So thank you for sharing your time with us.
Thank you so much, and doubly so because you taught me in pharmacy school. Oh my goodness! See, this is full circle.
Yes.
No, that's so beautiful. Well, thank you for all your wisdom today, Lucia. Thank you for your time, and I mean, not to share too much, but just going through a pregnancy as recently as you have to be on the ball, connecting all the dots, getting 0 sleep like you are right now, beyond impressed. I mean, just absolutely incredible. So thank you for your time, and we'll definitely have to have you on again sometime soon. I'm sure you'll be writing another 3 or 4 books that we're going to need to be able to
we'll see.
Another little one to write a book for. And so
there you go. I have another person to write a book with. How about that? Yes.
Any parting words for our audience, both the patient side and clinician side, you'd like them to be able to take away?
I think for me, the biggest thing is don't be shy to ask questions. I think a lot of times we're so scared to ask a question. Oh, the doctor knows what they're doing. Well, guess what? Health professionals are human. So we make mistakes. We forget things. And so as a patient, please ask questions. Don't be shy. Don't be scared. It will probably make that that healthcare professional take a step back and give you a better attention, better care, and look at the details of your medication list and make sure everything is where it's supposed to be. So that's my word of wisdom out there. Ask questions. Don't be shy.
Beautiful. That is so helpful. What a great way to end the show. Follow us on LinkedIn, Facebook, YouTube, Apple Podcasts, and Spotify. There they are right there, Lucia. I finally remembered them. All right, guys. Have a great rest of the day. Thanks for joining
me. Thank you both so much. Thank you for having me. And please continue doing what you're doing. This is beautiful. Thank you so much.
Thank you.